if you feel anything, but this could be one candidate. No?
Feel it tight.
Any pain? For me, this one is a bit more thickened, a bit more nodular, okay? So, for example, regarding the a neuropatient, you can also do some orthopedic tests or tests to make a differential diagnosis. So, when you have a patient which is usually having a pattern of walking which is crossing the legs, we usually, or I think that physios usually tend to palpate, and they usually attribute most of the guilty to this, to adductor longus, because you have to take into account that this muscle has a lot of septum, so perhaps when you are palpating you are going to feel this is very hard, but in fact they are just septums, okay? So sometimes this is not so affected, and it's usually more affected the gracilis. So what kind of test do you think we can do more or less to differentiate?
Lift the knee.
Okay, that's a good idea. So for example, what we can do is to say, for example, I was doing some extensibility tests to say first we are just checking, or then we can be a bit faster to know if there is some reaction. So imagine, regarding extensibility, if I'm finding a lot of resistance here and I just flex the knee and it goes a bit more, I'm going to think that the gracilis is affected, okay? But if it's not changing, perhaps this can be coming from adductor longus. Or what's happening, for example, if I do this and I have a lot of resistance which is speed dependent, but when I do this, this disappears. So this may be coming from gracilis also. So this is a good idea for you to differentiate, okay? So I tell that because always people say, oh, this muscle is having a lot of taut bands, a lot of trigger points, but even if you do drilling, they will be still there, okay? So if anyone gets to diminish, just tell them to check. Now, but if you see in an ultrasound, there is a lot of collagenous tissue. It's like usually the deltoid. You find a lot of taut bands, but these are the septums, okay? So we are going to see the dry needling, okay? For this, imagine which is the needle I'm going to use. I'm going to take this 4 centimeters, okay? But if you have a very thin, you can use 2.5, or you can use a bigger. This is possibly one of the muscles that the needle length is ranging the most, okay? De 4, sí. Déjame guantes y todo eso ahí, por aquí. Gracias. Okay, so we are going to put a bit of disinfectant. Okay, so I'm going to palpate and I tell you what I think and you confirm or not. So for me this is fine, this is fine, this is... I wasn't very convinced, but what about this? No. What about this one? No? Okay, so if I have the nodule here, remember what I was doing is to make a big rib and then I'm releasing a bit, so I'm just always doing this movement just to check where I have the trigger point, okay? So I have to spend a bit of time if I want to be good or precise enough. So I'm grabbing this. So in this case, this is very similar to what we explained for the thorax. What's happening if I put the needle here or here? The problem is that I have to incline it, so perhaps I will be losing part. So I'm trying to get close to my finger, but I'm going to lean this against so I can take the proper direction of my palpation. Okay? So I'm usually doing like this. So I usually put it very closer, but I try not to touch the needle, okay? Because if not, it's contaminating, okay? So I'm going to do the first insertion. Now, a bit here. Yeah? So I can work a bit more here. So if I have any doubt that I have lost the trigger point, I may check it, palpate it, and then go there. Do you feel?
Yeah.
Now, very good. Yeah. Very big, yeah. I think you are not seeing anything, no?
No.
But they are very, very big twitches, okay? So the good point, remember, of the pincer grip is that you are having a very good precision, you are feeling directly what's happening, so this is the option I always choose for this. But if it's very tiring because I have to be like this with a big needle, what I'm going to do, well, I'm going to simulate only is to palpate. Palpation is very easy because this is like the feeling of this muscle is mainly like latissimus dorsi, that it was very cylindric, very fibrous, so this is this type of muscle, but even more. So if you have located here, you just are over the top band and then you do it directly in this direction. But you only need to insert 2.5 or not more. Okay?
Cambia sitios que
Ah, okay. So you want to change?
Thank you.
Okay, so I was saying that I'm going to palpate. So the idea when I'm palpating, I think that it was a bit complicated for you when you are starting, but you are getting better every day, is I'm going to go through the muscle trying to feel if I feel any top band. So here I usually am doing this, so I try to pick the nodule, and then what I try to do is to go between my fingers, okay? So in this case,
it's important to know exactly where is all the muscles. Gracilis, okay, but the others one together, you take it as a adductor,
well,
or
it doesn't mind if in your grip you take a bit of other muscle, because for example here you cannot take just the gracilis, so you take a bit of more grip. But the important thing is that although you go through the other muscles, if there are no trigger points in that area of the muscle, it's not going to be painful. So it's mainly painful when we are reaching this area, okay? Or sometimes if you are taking a bit more tissue here, you don't need to go until your finger, okay?
Can you repeat how do we find the grasses?
Also all the palpation? Okay, so if you remember, we have from the anterior superior iliac spine, sartorius and tensor fascia lata. So this was like a triangle that was filled by the rectus femoris. So if you have a look to sartorius, here we have this lateral border with the rectus femoris, and we have a medial border which is going to form the medial inguinal triangle, okay, this one. So here in the lateral part you will have fibers from iliacus, psoas iliacus, and then in the medial part you will have the access to pectineus, but they are like in the bottom of the triangle. Here we also have all the blood vessels, the nerves, so this is a really complex area. So as a reference, when we are working lateral to sartorius, we are safe, or when we are working over the adductor longus or internally to it, we are also safe. So the only danger is if we are in this area. But we are working here, rectus, tensor, or adductor, gracilis. So this is some more specific or a bit more dangerous, but we are not going to cover this. So when you move here, it's very easy because you will feel a very hard, a very prominent muscle. If you have any problems to palpate, you just have to flex a little and do a little abduction like this, ABD. So this is the muscle which is highlighting here. So you can palpate the two surcus very well. So this is the surcus with pectineus here. So this is the surcus with gracilis. Okay? So what I'm going to do is to place my fingers. I palpate adductor longus, so I try to fall in this surcus. So from this surcus I'm going to pick gracilis, more or less here. Sometimes if it's just impossible to put your finger in the surcus because you only take subcutaneous tissue, you just take a bit more muscle. It doesn't happen anything. Okay? So what I'm going to do is to check what I feel. Okay? So I'm doing like this. So for example, if I felt a trigger point here, I do this pincer grip, I palpate, this is subcutaneous tissue, okay? So I go back again, so I take it properly. So what I'm going to do is to go in the direction of my fingers because the palpation has been done like that. So I just put it here, leave a bit of space, and we are going in this direction, okay? But if you have a lot of problems to make the grip, you can also put it like this. So I'm feeling, this is the surcus, the muscle, the surcus. I don't know if you can see the bump, okay? So what I have to do is, if I feel a trigger point here, just to compress and to go in the direction here of my finger. So this would be, remember, if you are palpating like this, this is the direction, but if you are palpating like this or like this, so you have to be based on your palpation, because when you are palpating and detecting things, you are making the compression in that plane, okay? So this is the best guide. Okay, any questions for this muscle? So we are going to have a look to the hamstrings, okay?
Yeah.
So in this position, if we are in the gracilis and we go to this posterior side, what are we going to find? Which muscle?
Semimembranosus.
Semimembranosus muscle, okay? You can find a bit of adductor magnus in the upper part, like a triangle, which is accessible, but the surcus will be with semimembranosus, okay? So if we ask the patient to lie prone, well, we can change the left.